So thank you, Jessica. Jamie Newell's here, Barbara Hanson,
Here.
Linda DeSitter,
Here.
Seiko Izumi,
Here.
Nancy Boutine. Oop,
Oh,
is Nancy
you're muted.
co-host? Yeah.
There we go.
Yeah, yeah.
Here.
Here. Good. All right. So we have quorum. Jamie, you can go ahead.
Okay, great. So I think, Mark, do you want to pull up the agenda?
Sure. All right.
Yeah, so I think it looks like first we are hoping Linda can give us an update on the ECHO program. And I know you had slides, Linda.
Yeah, and Mark's going to pull them up.
Yeah, I will
Okay.
pull those up for. Okay, can everybody see those that need to be bigger or okay?
Looks good.
Okay. All yours, Linda. Go ahead.
Okay, so just real quickly, you all know that House Bill 2981 passed, and the rules came out at the beginning of the year. And there's lots and lots to do for implementation of it. But one small step is education. And one small step of education is a palliative care echo that's happening right now. And I'm going to give an update on it. Next slide. Just for those who don't know what ECHO stands for, it's that. It's a tele-mentoring learning framework for rural and undersourced areas. So it really focuses on rural areas and undersourced areas, which is basically everywhere for palliative care. Our ECHO network is run through OPRIN, and we got two sessions scheduled, two 12-week sessions scheduled, thanks to a grant from Cambia that Aaron applied and got. So we are currently coming up on finishing the spring session. We just finished, this will be week 11 on Thursday, and we will have another 12-week session in next winter. It offers free 12-hour CME to all 60 participants. It's highly structured. It's didactic, then a case presentation, and then a facilitated discussion. And it really aims to bring in community knowledge. So we really foster that people really do know a fair amount. Next slide. These are the four faculty. Erin Collins is our lead. She's the one that got the grant. Arica is a social worker, Kelly is a nurse, and I am a physician. And this is typical of the ECHO program where you have a very interdisciplinary team. Next slide. These are where the participants are from, so you can get a sense of the map. I'm most excited about all the rural areas. 90 people registered, and they only accept 60. They made an exception and took 3 more. I can't remember why. But we get regularly about 30 to 35 each session. And this is just an ECHO policy to only allow 60 because they feel like it creates a better learning environment. You can see where people are from and what counties they're from. And they're different disciplines. So you can see there's 15 docs, 17 docs, 8 social workers, etc. So next slide. This is the curriculum, all 12 weeks. And I show this because I want to emphasize this is Palliative Care 101. It is barely doing the surface, okay? For those of you who know about Vital Talk and Advanced Care Planning, that's session number 2. And in 20 minutes, Arica and I covered all of Vital Talk and Advanced Care Planning. So it is 101 barely. In session 6, I covered everything about pain and dyspnea in 20 minutes. So obviously there's a lot more education needed if people are truly going to be palliative care providers. Next slide. So that brings me to my last slide, which is further educational needs for implementation, for the educational part of implementation. So we have one more ECHO, so one more 101, but we don't have palliative care 102, 103, 201, 202, 203. So people who are really going to be doing the palliative care are going to need more education, and we have no system yet of how to make that happen. The other thing is that even if people go through 203, they are going to run into cases. You can see it in ECHO. They're going to run into cases that they don't know how to deal with out in the boondocks, and they have nobody to call. There is no consultation support. So I've actually talked to Jason Webb about this because OHSU has a fantastic consultation support system for cardiology and other things where people can call in and get questions answered. But they don't have enough palliative care staff or FTE to provide consultation across the state. So this is a huge deficit and something that I think our committee ought to be discussing, both ongoing education past the 101 and how do we support a consultation service for these poor providers in any discipline out there who don't have somebody to ask a question of. That's it. I'm open for questions.
This is fantastic. Thank you very much, Linda and Erin. So what are the participants are saying so far?
The what?
Participants, what are they saying? Their responses?
They're very excited about it. They are feeling like they really like the didactics. Lots of comments about I would have liked to have more of X, but I know we have time limitations. So we're getting good grades. We're getting asked for more, and some of the case presentations are very specific questions that we can answer in the context of ECHO, but if the same question comes up 3 weeks from now, there is nobody to answer it.
I see. And one more quick question. So you mentioned about the this is 101, and you mentioned about the 102, 103, so forth. And is that planned or that is what you are hoping to as a next step?
There is no plan. So, I mean, I assume that there is, or I hope that OHA has some kind of implementation plan. I would if I was in charge. And if I was doing this through Providence, I would have already had an implementation plan. As far as I know, there is no plan for further education. And ECHO, it costs about $50,000 a session. So that mechanism is a great mechanism and very well supported, but it's expensive. And so I would doubt that OHA has $1 million sitting around to allow us to continue the ECHO program at 102, 103, 104.
Was the grant from Cambia for the 100,000 or was it some lesser number?
It was somewhere around there. I actually don't know. The person who knows is Erin, who I am presenting for. She's the lead faculty person, but it only covers the 2 ECHO sessions.
Are they open to another grant request?
I don't know. That's a great question. I mean, Erin and I have talked about that possibility, and Erin's a wonderful lead faculty person. So with our great certainly if OHA wrote a letter of support, I think our chances of getting it would be higher. So that might be something that our committee would ask OHA to provide is a letter of recommendation for grants providing further education, either more of the 101 or 102, 103 kind of thing.
Yeah, I think that's a
Linda,
great idea. Oh, go ahead.
Sorry, this is Barb. Linda, I wondered, so there's going to be a repeat of this 101 ECHO, and when will that be?
Winter, so starting in January 26.
Okay,
And then
thank
that's
you.
it. Yeah, that's it. There's no funding for any more. And unless some money magically appears, which I'm not holding my breath for.
Yeah. Yeah, I think that idea of seeing if there's more grant money for more advanced teaching would be great. I have a question about the consultation service. And I know you and I talked about this a little bit. I think that's such a fantastic idea. And I know, when I think about it, OHSU is the logical place for that. Since he's not here, what was Jason's thoughts? What were Jason's thoughts about that?
He said that was an interesting idea, something he was going to think about. He would need more FTE, which he doesn't have. In fact, you could almost hear him like take a deep breath and sigh because they just filled a new FTE. In fact, they're stealing one of the docs from one of the hospices I locums for to fill that FTE, which is why I'm going to be working more this summer, but more than I want. But uh, they would have to get more FTE from OHSU, and then they would have to recruit those people, and then they would have to set up a system for consultation, feeding into the system that already exists at OHSU for all the other specialties.
Yeah, so that's a big lift.
I mean, I would guess we're talking $1 million a year, just as a ballpark figure of what they would need, and the CCOs would be smart to provide that money, but I am pretty sure that the CCOs are not thinking that way.
Yeah.
Linda, do you know if it was recorded or if there's access to reviewing any of that content?
Great question. Thank you, Mark, because I pushed really hard to get it recorded, the didactics recorded, not the case presentations. So there's 20-minute didactics, and all but one of them has been recorded, and the one that wasn't was a screw up in technology. And so whether it gets released and to where, I don't know. I pushed hard for it to go to OHA. If there is a repository, I mean, I think we could put it on our website. So that would be something else for this committee to decide is if ECHO releases it to OHA, would we support, for lack of a better word, having it on our website?
Either that or even providing a pass-through link or some type of, page on our, that's in a whole nother discussion, but I think it'd be nice to have that access or at least advertise it.
And ECHO doesn't have a mechanism to have a repository. So and I got the feeling like it's not a bad idea, but we're several years away. So if we want to make it available easily, I would say that that it's probably putting it on our website would be the ideal. And it's 20-minute presentations. There'll be 11 of them.
Well, by the time you run it the next time, there'll presumably be 12.
Yeah, and we can have session 1, session. I mean, we can label it any way we want on the website.
Mm-hmm.
I'm looking at Mark as I'm saying that because, of course, I'm not going to do that work. But
Well, I think as long as we have access to any of the video assets, that's not a heavy lift to be able to either. I mean, it's certainly not if you want to put a link on our webpage, but I can talk with Jason some more about it, and we can explore, Linda, if you do come up with access to it or know of how we might get access to the recording, that'd be good.
Yeah, I think if you said, Mark, if you could send me and Aaron emails and say, we have agreed that we can house them on the website. I'm waving my hands because there'll be more words, but then Aaron and I can push ECHO to release them to you.
Mark, do we need a motion and a vote from the council on this?
Oh, It's a good question. Um, mm, I would say let's
Well, how about if we just err on the side of, I will make the motion that we pursue getting access to the recordings of this year's sessions to make them available on the PCAC website.
Yeah, sure. I think that'd be fine. Something a little bit more general in scope. And then if it's, a link or if it's an actual video, then we can make that decision internally, whether what to do with it. I mean, certainly we'd have to review it, make sure there's no conflicts of interest, any of that kind of stuff. But I doubt that there are for an echo. So
I second Barb's motion.
Okay, so sounds like that motion is passed.
I think you have to take a vote, Jamie.
Oh,
have a discussion if there's any comments, and then a vote, and then I can make a roll call vote.
yeah. So let's take a vote. My vote is aye.
And Jamie, okay. Barbara Hanson
Aye.
and Linda.
Aye.
Aye. Seiko Zumi.
Aye.
Nancy Boutine.
Aye.
Okay, motion is passed. And I will explore putting the content on the PCAC website.
Thanks, Mark.
You're welcome.
Can I go back to the question to the echo sessions?
Of course.
And
Yeah,
do you have
we've got 2 more minutes.
Yeah, okay. So you said that you have the 90 registration and you take the 60 some participant this time. So next round will be you already have about 30 of them on the list. And do you think if you train the 90 people, then that will cover the general needs, or do you see the needs of the repeating one-on-one session to even spreading the palliative care principles or the one-on-one to the further population? What is the needs, do you think?
If I were going to guess from having worked in rural Oregon for a while, it barely probably scratches the surface, 5-10% of the need.
Yeah, I think that would be when you do I assume you will do the evaluation at the end of the series or the session. Then they ask them that they are the people on the ground, and do you think that they know somebody who wants to participate and benefit from this kind of session, so we can have some sense of what the needs are? Then that will help us to determine should we move forward to be the repeating the one-on-one versus developing the 102 or something else. So I think if you can use this as an opportunity to do the kind of needs assessment, that'd be super great.
That sounds great. Thanks, Seiko. That's a great suggestion. And I have no idea how ECHO's rules are, but I will recommend that definitely.
Are there any other viable options besides Echo to try to reach out to the providers that have, I assume part of Echo is that there is some protection in terms of information that we're sharing. And I mean, 50,000 seems like a lot given that everybody and their grandchild has, a Zoom account.
I don't know anything about the rules for ECHO. That'd be a great question for Erin. So if you want to email Erin,
Okay.
Who's part of our committee, she can give you a better answer than I could make up.
I mean, just off the top of my head, could OHA host a meeting that providers in the state could tune into?
I know just from doing previous echoes myself, and also looking at the cost and going a different route and saying I'm going to not spend as much money to do an echo, but I still had to hire a company to facilitate that, to get it done. And that was in my private business, but as far as the state is concerned, it's just going to, it would take resources to both facilitate and do that, and time and money and budget and staff time to,
Okay.
you know, 50,000 would be, you know, what the echo would cost. You know, you're looking at least 20 to 25K to pull something off like that.
I see. Okay. Thank you.
You bet.
Another possibility is that the grant, getting the grant would be great, but because if we do eco style training session and participants pay for that. So trainees who is participating, they pay for just like the regular training. That cover may not be entire $50,000, but some part of it. And advantage for this is that this time it's free, but they get the credit, so CE to be the part of the 16, 12 out of 16 credits there needs to be trained in the palliative care. So that is advantage for them. So there may be the way to kind of the pitch it to at least participants pay for some extent to getting there the CE for the as a palliative care trained person.
Yeah, I mean, there's a lot of to pay CE out there already, through CAPC and through HPM and other places. So I'm not anxious to go and recreate paid stuff, because I think people can get it. There's the California State University certificates, there's the Washington one, there's conferences. So I think so my experience with developing rural programs is people don't know that they need the information. And so any barrier that you have for them getting that information is a barrier. And so having it free reduces one barrier for them to get information that they didn't know they needed. So,
but the people who have already done 11 echoes clearly understand that that you're just scratching the surface, right? Because you say they're asking questions and they understand that there's no time, there isn't enough time to be a fellowship. So their barrier might be lower than somebody coming in for the first time. Maybe you could ask a question if there was a follow-up that would complete their 18 requirements or 18 CME requirements if they would be willing to pay.
I can make that recommendation too. Again, I would be surprised if we got more than a handful of people, but
Okay.
I can ask.
I can look into this more, and I'll talk with Jason, but we probably should. Sorry to cut off the conversation, but that was wonderful. Thank you, Linda, for the presentation. But Jamie, we should probably shift along.
Okay, sounds good. Do you want to pull up that agenda again, Mark? So it looks like Cheryl was going to give us an update from her end, and I believe Cheryl is on now, correct?
I'm sorry, I missed the last bit of what you said.
Oh, I just said that Cheryl, that you were going to give us an update from your end, and I was making sure you were on.
Yeah, so I'm on with my colleagues, and we're going to have more information. And it looks like I'm having some bandwidth issues, so I'm going to turn off my video if that's okay with folks. Thank you.
Thanks.
So I'd be glad for you to get this slide going.
Okay, hang on a second. I'll get those going for you, Cheryl.
Great, thank you. And I'll go ahead and start talking while you're doing that. I appreciate it. So good afternoon, everyone. We're glad to be with you. We are with the CCO Operations Unit in OHA's Medicaid Division. I'm going to introduce myself and then hand off to my teammates for their introductions. So I'm Cheryl Henning, she, her pronouns, CCO Contracts Administrator. So the main part of my job is to manage the annual process for updating the CCO contracts and then working with the internal subject matter experts and the Department of Justice to draft the actual contract language for the approved changes. So I'll hand off to my colleagues Veronica and Leslie for their introductions, and then we'll dive in.
Hi, everyone. Good afternoon. My name is Veronica Guerra. I'm the CCO Operations Deputy Director, and I oversee the Quality Assurance Unit. We oversee quite a few of the deliverables and own several deliverables that the CCOs have to report to OHA around a variety of different subject areas. And so today we'll kind of walk through some of the changes that have been made to specific deliverables as it relates to this work. I'm going to hand it off to Leslie to introduce herself.
Greetings, I'm Leslie Ains, I use she, her pronouns. I am the manager for the Quality of Care and Compliance team. I work alongside Veronica Guerra with the Quality Assurance team, implementing the work around the deliverables and compliance of those deliverables. So I'll hand it back to you, Cheryl.
Thank you. So as Veronica suggested, we're going to be talking about a lot of information in the CCO space. So we're going to give you an overview of the current contract requirements related to the palliative care program. We're going to talk about how we're currently monitoring CCO compliance with the program requirements, and then talk about the current and future processes to update the CCO contracts. And so we're hoping that this information will help the council start planning for what it would like to propose in the future as CCO contract changes. So if you can go to my next slide, please. Thank you. So this first slide is pretty straightforward.
Cheryl?
This is literally what is in the CCO
Cheryl?
contract regarding the palliative care program. Yes?
Cheryl, you're cutting out. You might want to turn off your video again.
Yeah, I'll turn off the video again. Hopefully this is better. Thank you. I thought it had resolved, but apparently not. Great. Okay, so as I was saying, so this is the literal contract language about the palliative care program. As you can see here, it's very short, and it points primarily to the Oregon administrative rules for the details of the program. And I've included the citation there to the specific part of the contract and even a link to the contract. Next slide, please. So these next several elements get into CCO requirements around provider contracting, which is certainly relevant to the palliative care program. So for each of these, I've identified the citations that are relevant, whether it's the Federal Code of Regulations, Oregon administrative rules, or even the contract itself. And as a general piece of information, the federal regulations are the higher authority, then followed by administrative rules and then contract. So in some cases, just a couple are relevant. In other cases, it's all three. So in terms of provider contracting, when a provider gets a CCO contract, they are called a participating provider or a network provider. A lot of you all in healthcare space have probably heard the term network provider. So a CCO needs to have policies for how it does provider credentialing, which includes how it selects its providers and how it maintains its network. So here's a really important piece. So CCO does not have to contract with any provider that wants a contract, and it doesn't have to contract with any more providers than is needed to meet its members' needs. That's a very complicated topic unto itself, but just a good piece of general information. So if a CCO declines to contract with a provider who's asked for a contract, then there are official things the CCO has to do. They have to give the provider written notice of the reason why they said no to a contract, a copy of the CCO's provider selection policy, and then tell the provider how to use the CCO's internal process to have the CCO review that decision not to offer a contract. Next slide, please. So this slide is going to illustrate the situation in which OHA would get involved in the CCO provider contract matter, which, as you can tell from the previous slide, CCOs have a lot of control over their provider networks. But in the case of A provider who asked for a contract and the CCO said no, if the provider believes that the CCO said no based on that provider's license and certification, then the provider can ask OHA to get involved by reviewing the matter for possible discrimination. There's a very official process for that to happen. There's even a link to that provider discrimination review form in the slide deck. And the process for OHA handling that appeal is in rule, and the party that loses the appeal must pay the legal costs of the party that wins the appeal. So again, these two slides, CCOs have a lot of discretion in the provider contracting, and OHA generally doesn't get involved. And this is all stemming at the highest order from federal regulations relating to Medicaid managed care. So I'm going to stop here and hand off to Veronica and Leslie, and then I'll come back later in the slide deck.
Thanks, Cheryl. Next slide, please. Okay, so we are, as we talked about, as I mentioned very briefly earlier, we've made some changes to the various deliverables, a few deliverables that exist within our quality assurance unit, in order to incorporate requirements related to the palliative care program that will allow us to monitor this benefit. So the first deliverable, we'll kind of go through them here and talk a little bit about what is included within the various deliverables. But the first deliverable is the member handbook. Every year members any member that's enrolled with the CCO receives a member handbook. It has a description and kind of compilation of all of the services and supports that are available to a member. And so specifically, there is a section in the handbook that covers benefits and whether there is, so provides kind of a description of the overall benefit, any limitations on that benefit, and then also provides information about any authorization or approval process that would need to take place for the benefit as a whole. And so this is just broadly speaking about the section. And so the palliative care benefit has been included in the model handbook as a service that is referenced within the overall benefit table. And so it provides members with more details about the benefit and how they might be able to access that benefit. And then a few additional points, as you can see here, my team does a pretty thorough process to prepare evaluation criteria for the member handbook, and we also review the member handbook and approve those member handbooks when they come in. So we are looking at all of the information that goes into the member handbooks to ensure that it has an accurate description of the service, and also further information for the member to understand how to access the service. And I kind of generally spoke about, this is a document that goes out to members every year. It is also required that so members who are new members receive a hard copy version, and then any current enrollee will receive an electronic version or have access to the electronic version. So the handbook has to be posted to the CCO's website, and the CCO has to notify the members that that electronic version is available for the member to access. And then, as you can see there as well, if a member has a request for a hard copy of that member handbook, they also are required to provide that document to them in their preferred language, or if they need some kind of auxiliary aid for that document. Next slide, please. So now I'm going to jump over to a different deliverable. This is another deliverable where we have made some adjustments and some changes to capture and again oversee this specific benefit. So we have a different deliverable that's called a Delivery System Network Provider Capacity Report. This is in essence kind of an inventory of all of the providers in the network contracted with each CCO. And includes individual level data, so individual provider level data, and also facility level data. And so we receive these reports twice a year, in the first and third quarters of each year. As you can see there. And again, we have pretty detailed instructions and kind of process laid out for the CCOs. We have, as you can see, you can access the links that are the documents that are linked there. But we provide the CCOs with the template instructions, and then also with the provider specialty matrix, which is in essence it's a document that includes all taxonomy codes that would be relevant to any provider types that are contracted with the CCOs. And so those taxonomy codes get reported in the biannual provider capacity reports. And those taxonomy codes are really kind of the basis for some of the data analysis that we do. So we can use those taxonomy codes. We've identified a few taxonomy codes that are related to palliative care. We can use those taxonomy codes to look at the number and types of providers that are available within each CCO's network and contracted with those CCOs. And so with that, I'll jump over to the next slide, and then we can kind of take questions here at the end once Cheryl wraps up. And then the next deliverable that we have made some adjustments to, these are kind of broader adjustments, but will allow us to also oversee this specific benefit. And that is the grievance and appeal logs, I should say. And so I've included kind of a general summary for you, or definition of a grievance and an appeal. But these logs are intended to allow us to monitor the grievance and appeal system, which is comprised of grievances, appeals, service denials. I should have done that in a different order. Grievances, service denials, appeals, and prior authorizations, and really be able to kind of see what is being authorized by the CCOs, whether there are denials that are occurring related to specific services that require an authorization, whether there are any denials for payment of claims for those services that do not require an authorization. And then finally, are there any appeals that are being submitted by the enrollee or the representative or provider if they do not agree with the denial decision made by the CCO. So that's what the logs generally capture. We've modified those logs to include a few additional reporting requirements that rolled out this year in Q1 of 2025. And that is to include diagnosis and procedure codes, and that will really kind of allow us to assess access to this palliative care benefit using the logs in future submissions. Again, we have a pretty detailed and defined process for the template and the reporting instructions for this deliverable, and that's all laid out pretty clearly for the CCOs. And next slide, I think that was my last slide. Let's see. Yes. So Cheryl, I will hand it back to you.
Great. Thank you so much, Veronica. So we're going to get into some pretty dense content, and I will try not to go deep in the weeds, especially for the sake of time, but I do want you to understand the process for actually updating the contracts. So some basic information: the current CCO contracts were awarded in 2019 for the 5-year period of time starting in 2020. And this is referred to as the CCO 2.0 contracts. Many of you have probably heard that term. The 2023 ledge extended them by 2 years, so now the contracts are through 2026. So we started the process internally preparing for next set of contracts to begin in 27 last fall. And so the process for awarding public contracts is called procurement. So we've been calling this the 2027 procurement. So within that multi-year contract period, we do update the contract each year through a very structured process. We call it restatement, and that's because the actual annual contract is called the amended and restated contract. So we start that whole process in January of the year before the contract in question. So for example, we started the process for the 2026 contracts in January of this year. And this is all driven by a date in statute that says OHA has to give CCOs the final draft of the next year's contract with all the payment rates to each CCO by August 19th. So that is a date in law, and so we have to build our process to comply with that date. And so this means that the process for updating the 2026 contracts is nearly done. Next slide, please. So for the contract updating process for this restatement, there are very special steps for what we call significant changes. As the name implies, these are big deal changes. We have a definition of these that talks about if they're new programs or requirements or changes that CCOs or OHA might not like. It might be a lot of extra work or a lot of extra money or any combination of those. So the proposals for these significant changes come from our internal subject matter experts, and they were due this past February. And to even start the process, there's I think it's a 16 checklist is completed by the proposers, the internal subject matter experts, and those proposals have to be reviewed by multiple internal OHA groups like the finance folks and the rules folks. And then they have to be presented to CCOs in 2 different dedicated forums and also approved through a 2-step leadership process. And when the internal subject matter experts are making these proposals, they have to have a very strong justification if there are new or different reporting requirements, which typically we call those deliverables. So something new that CCOs have to submit. And they also have to be able to support what they're proposing in their proposal, meaning that just because there's something in the CCO contract, that doesn't mean that the unit that Veronica and Leslie and I are part of, we don't do all of that management of reporting. The subject matter expert team that has the knowledge for a particular topic area, in most cases, they're responsible for implementing a big change, for evaluating any reporting, and for corresponding with CCOs about that reporting. So it's a pretty diffuse process throughout the agency. Next slide, please. And so talking about going forward, starting with 27. So as I mentioned earlier, we've been working on the 27 procurement, and we submitted written testimony to the legislature, and by we I mean OHA. We submitted written testimony to the legislature that we would be extending these current contracts, which right now are through 26. We would extend them through 2028 when the governor signs House Bill 2205. And 2205, in a nutshell, says that CCO contracts must be for at least 5 years, and that beyond that 5-year initial term, OHA can choose the length of the contracts. So OHA would be exercising that discretion by extending them for 2 more years. So what's going to happen with pausing the 2027 procurement is that we're going to switch to a process that collectively covers the 27 and 28 restatements, and then the work on the 2029 procurement, because that will be the next set of brand new CCO contracts. And so we're still working through the details of this multi-year process. And so we expect to release that publicly next month. And it's going to build on what we have been learning through the 27 work to date. And it's important to note that the current restatement process will actually change going forward. For 27, the process will start much earlier than in prior years. And even the proposals will be due much earlier, and we will require the OHA subject matter experts to be working directly with CCOs as they're developing the proposals, which is a big departure from the historical process where CCOs generally don't know about the proposal until we formally present it to them. And these changes are a part of other commitments we've made to the legislature in some written testimony that we submitted earlier this session. So next slide, please. And that may be actually my last slide. It is. Okay, perfect. So having given you all this background, especially about how the 2026 restatement process is basically done, and that we're going to be pivoting to the process that covers the next 3 contracts, 27, 28, and the contract for the next procurement. This would be an opportunity for the council to perhaps start planning for how it may want to prepare, dive more deeply into changes it wants to propose as early as 2027. Even though the details of the process won't be released until next month, it's not too early for the council to start diving into the details of what it might want to propose. And maybe that involves a subgroup of some sort to focus on the particular topic. We as the CCO operations unit, we would certainly be available to educate that group about the details of this future roadmap process. We could give some technical assistance and background on how we think about CCO deliverables, like new reporting requirements. So we can certainly be a resource to the process. But I think what I'll do is pause there and hand off to Mark to add any further commentary and potentially invite questions.
I think we can open it up. We have probably till about 1 o'clock here looking at the agenda. Jamie, just so you're aware, we don't have the public comment. Nobody signed up for public comment, so we do have some extra time there, about 10 minutes at least. And Cheryl, just one question. I know that there was some mention of collaborating or working with CCOs to develop proposal content. Is there anything more specific you can speak to on that? Is it one CCO? Is it multiple CCOs? What's anything there?
Thanks, Mark. That's a great question, and kind of the question du jour, because we're still working on the specific details of what that will look like. What I can offer in this moment is that the intention around it, there's 2 parts. One is to make sure that we within OHA have fully thought through how some big change, like something that may affect CCO operations or provider contracting or what have you, that we within OHA know what the impact on CCOs would be operationally and can plan for how to appropriately operationalize that change. What so often happens, and I've been here this is my 6th restatement cycle, and Veronica's been here for just as long. What we found is year over year, there are proposals that are put forward by our internal folks that may not take into account how CCOs actually do their work internally. And as you probably heard, once you've seen one CCO, you've seen one CCO. Each CCO functions differently. And so having the benefit of CCO input in developing the proposal, that's going to help mitigate some of the consequences of CCOs not being able to implement a proposal as it's been approved through the process that didn't fully benefit from their involvement early in the process. The other piece is that we are aware that we within OHA don't know all things. So beyond being able to more successfully implement a proposal and for CCOs to operationalize it, we also just don't know all the factors that may be involved in a given topic. So having the CCOs be at the table with our internal folks in developing a proposal, that's going to help us contemplate things. Maybe there's a problem and our internal folks have an idea for a solution that normally would be the proposal, but in this new construct, the CCOs can help craft what the proposal actually looks like because they have additional information that we as OHA just may not have because we don't know all things. And so that's some of the thinking behind this engagement work. But again, the specifics have not yet been figured out, but that will be an expectation of proposals starting with the 2027 restatement, is that the OHA subject matter experts will have been engaging with CCOs by the time they submit their proposal to be officially considered to work through the whole process. Hopefully that's helpful, at least for now.
Linda?
Thank you very much. I learned a lot. Thank you for the presentation. And I have a million questions, so stop me if I'm extending my my time here. My first question is, when you say subject expert team, who is that in OHA?
So that is a great question, and depending on how deeply you know how the CCO contract is organized, you may know, for example, like there's content about value-based payments. There's content about quality improvement efforts. There's content about directed payments, behavioral health, care coordination, all those different topic areas. There are literally people within OHA, and it could be the Medicaid division, it could be the finance and operations division, it could be the health policy and analytics division. There are people throughout the agency who are the parties who sort of own that content area in the contract. And so they're the ones who are responsible for developing and helping to vet proposals to affect that contract content.
So so as the Palliative Care Advisory Council, it would be really nice to be able to talk to the internal experts within OHA who are responsible for vetting things around palliative care. Is that possible?
Yes, and I think understanding more specifically what sort of CCO contract requirements that the council might be contemplating, that will help us target which particular subject matter experts are relevant, because there is not a single palliative care SME, but there are multiple SMEs whose content areas do have some relationship to the palliative care program. So it's definitely not one single individual.
So would it be possible for members of this council to go to a subject matter expert meeting where they are discussing the proposals and offer some expert advice?
So the process doesn't quite work like that, but I would be glad for Mark to jump in.
So Linda, I think what Cheryl's saying is, let's say the council or the council would like to understand how can you include a alternative payment methodology or value-based payment in a requirement for a contract. Then you would seek out somebody that handled that within OHA and have a discussion around how do we word that? How can it be put in a contract? What's the chances of that happening? We have done that in other ways. I think historically we've actually worked with like the Transformation Center as a outreach arm of OHA to have listening sessions with CCOs around that very topic. And they didn't get a lot of positive response around it. So I think that was like, okay, well, that's a heavy lift to put into a contract. Do you really want to go down that road? And so if you're talking about adding metrics or something, then there's probably, it would start with me and Jason and Cher and Krista Mars. We kind of then reach out into our contacts within the agency to find out who are the experts that we need to talk to and engage with to define that moving forward in the proposal.
And so that would also be true if we would recommend a different wording around what's in the example member handbook and that kind of thing. We would go to you and Jason. We would say, hey, we recommend that it look different, the wording be different. And then you would reach out to the people who actually do that. Is that how it works?
Yeah, we could have some discussion around that internally on how best to handle that. Yes.
Okay, and then I have one more question. I'm going to turn over to Seiko because I'm hogging this. I'm sorry. So we should have Q1 data already about taxonomy codes and stuff like that. how does that get compiled, and can the public see it, or can this council see it?
So this is Veronica. I can speak to that. We just received reporting not too long ago, and we're in the process of um, kind of going through our data cleaning process and doing all of that work to prepare the data to be analyzed. We I think we do, so at the end of the process, after we're done with all of our data analysis, we produce evaluation reports for each CCO. Those evaluation reports could be shared with the council, or we can pull out the palliative care taxonomy pieces within the evaluations. But we kind of have to go through our process, which takes a little bit of time in order to compile those evaluation results.
So would it be, so I would like to make a proposal that we invite Veronica or somebody from her team to attend our next meeting and present what data they have and can share with us so we can start being helpful from the educational perspective.
And I think that's something that we can certainly, Jason and I can work with Veronica on
Yeah, and I think again, we're happy to share the reports. They are publicly available. If folks want to be able to kind of dig through the reports themselves.
Oh, I'd love to. If you can let Jason, if you can let Mark have the link, then he can send it out to us. I think Seiko and I, at the very least, would be very interested. Probably Barb.
Yeah, sure. Yeah, no
And
problem.
then Linda, we can work with Jamie and Barb in leadership meetings to decide, okay, what do we want to include on the agenda for September, and how do we want to structure that, put together a presentation, whatever. If we ask, Veronica and Cheryl and their team again to come visit and talk, then they've got the time, great. If not, we can certainly make that the highest best use of the time for the council and make it an effective presentation. And Seiko?
Mark, I do need to log off. I am so sorry, everyone, but we have to run to another meeting.
Thank you all for being here. Really appreciate the nice presentation and the information for the council.
Thank you all.
Very helpful.
Have a good one.
Thank you very much. So my question is somewhat related to what Linda asked, but I'm also curious, and I'm very confused because it sounds like the first quarter data is in, but I have no idea what kind of code was used designated to flagging this is a palliative care related, and how they are collecting data, because the 20 House Bill the 2981 become the active from the January of this year. So does that mean that the past year, prior year, they already developed, and they're developing the handbook explaining this and as a benefit? I have not seen any example of how this service is offered to the member, and if it's already done, then how much they are charging, how the contract of the how much to pay is contracted. I haven't seen any example of that, and I have not heard any discussion to determine that. So I am super confused. Maybe I am the stupid one who does not understand, but I would appreciate some description of what has been done and what kind of data collected, and what is the actual process of the contracting to pay for this service.
So there's a lot of questions. There's a lot going on in there, Seiko. I'll do my best to kind of try and address some of that. So you have general data collection that the state collects on all medical services, and then they can nail it down to whatever codes they have in their taxonomy to pull data. Now, that's going to be not just germane to this program, right? That's going to be any kind of palliative care service. So
Yeah,
then
but
there's
I don't know that there's any palliative care specific code exist.
So I'd have to ask Veronica, but I think there is some data that they can pull somewhere, something that falls into that, but I'm not positive.
Yeah, I'm not
Jason, do you have
positive.
anything to add on that? Hey, you're muted, Jason. Oh, Cheryl, do you have your hand up?
Yeah, and I think Jason might still be muted too.
Okay.
I was just going to note, and thank you, Mark. Just going to note that so far what's happened is that we have integrated palliative care elements into existing CCO contract requirements. So meaning existing deliverables. We've not created brand new things specific to the palliative care program. That's the kind of work that would come as a result of the council's deliberation on what palliative care specific things it would want to propose for future contracts. The process for creating something specific to palliative care, that would be a very lengthy, involved process, and we simply did not have the opportunity leading up to the 2025 contract to do anything specific to the palliative care program. But what we were able to do is to integrate palliative care into some existing deliverables that otherwise cover large books of business connected to the CCO contract.
Can I ask a couple of questions? Sorry to not raise my hand. This is Barb.
Yeah, go ahead, Barb.
Sure. And as I understand, did Veronica leave, but Cheryl and Leslie are still on, or?
Just Cheryl is still here.
Okay. Okay, gotcha. Thank you. Well, first of all, thanks for the presentation. Really useful information, and it will take a while to digest it all. But my two questions are more basic. I've been trying to see on the OHA CCO website if there's any list anywhere of each CCO and with whom they have contracted to be a palliative care, either participating or network provider. Is such a list available anywhere?
Thanks for the question, Barb. This is Cheryl. So OHA does not publish on its own website provider contract information. Rather, each CCO has on its own website their member-facing list of contracted providers. So that is the easiest, most publicly available resource. Another option is in the delivery system network provider report that Veronica discussed. That's a very detailed spreadsheet that CCOs submit to us every twice a year for a quarterly basis. So that's one of the reports they've already received for this year, and they're still working through all 16 CCO submissions. They have to check the data quality and the completeness because we have to use it for other analytical purposes. But that would be a report that we could potentially extract provider contracting information from for the council. So when Veronica comes back in September, for example, she should be able to share with you what contracted providers for palliative care showed up in that report.
Okay, thank you. So there are 16 CCOs, is that right? 616?
Yes, and I say that with a question mark only because there are 16 service areas, but technically 12 companies, because like Pacific Source has 4 different service areas, so it counts as 4.
So my second question is, I've heard from a couple of palliative care providers that they have been unable to get a meeting with their CCO to discuss a contract to provide palliative care. So they can't file a grievance, at least as I understand it from your slides, because they haven't been selected. They haven't even been, able to get a meeting. So to whom should they direct a question at the OHA? Should I direct them to you, Cheryl, or Veronica? Or I just thought, it's just they're really frustrated, and they're in one instance, and these are in Central and Eastern Oregon, and in one instance there really isn't any other palliative care provider, so it would seem that there's no palliative care contracted provider in that area. So anyway, they're frustrated, and I just want to direct them to the right person to ask and they've tried multiple phone calls and emails with the CCO.
So thanks for the question. So my first recommendation is to first make sure that the provider is contacting the CCO's contracting department, and I can put a link to our CCO webpage that has CCO's provider network contracting contacts. So I would first advise providers to make sure they're contacting the correct party within each CCO. And then secondly, if indeed they have made that attempt and they've received no response after a reasonable period of time, then you'd be welcome to reach out to myself and Veronica. And I would also encourage you to include Dave Inbody, the CC Operations Director, and I'll put all of our emails in the chat, and reach out to us to say that the CCO has been non-responsive. At that point, our intervention would be to essentially contact the CCO leadership and say, hey, this provider says they've not received information related to the request for a contract. Could you please have your team respond to them? But we couldn't, for example, help the provider get an appointment with the provider contracting department. We can just simply elevate the non-response to leadership within the CCO. And then if the provider continues to have no response, we may pursue something higher. But initially, I think that's what I would recommend.
Okay, thank you very much. And I'll rely on some of my colleagues on the council to collect your email addresses or any links you put in the chat, since I'm driving and that would not be safe. Thank you.
Yeah, Barb, I can get that and send it out to the council members so that we have it via email. Jamie?
Yeah, thanks. I think I'm still grappling with, and Linda alluded to this as well when she was talking, I'm still grappling with this knowledge now of the subject matter experts and just kind of the purpose of our council, and a little bit shocked that our council wasn't pulled into any of those discussions about what would go into the contracts when, you know, really the council is made up of people, boots on the ground, who have the most palliative care expertise and have had ideas for, you know, years now about what should go into these contracts.
So Jamie, you're saying, I'm not sure what
So,
you're saying.
I mean, it's not so, I guess it's not so much of a question as a statement, but I guess my question is why the subject matter experts haven't consulted at all with the council about what goes into the contracts.
I'm guessing because the law itself does not require some of the stuff the council has been asking for right now. So if you're asking for deliverables to be added to the contract, that's not in the statute, right? So in order to make a change, you'd have to have, at least my understanding was in the last contract, 2025-26, you would have had some statutory requirement that would support that change. And there's no statutory requirement to include, you know, a deliverable of metrics collection, for example.
I guess, Mark, we understand that there's probably a legal reason why you didn't contact us, but our feelings are hurt. We have some really smart people on this council, and it surprises all of us and hurts our feelings that nobody contacts us and asks for our input.
And even determining what the deliverables should be, like from the very beginning. Yeah.
Yeah, I think that's a tough spot to be in, you know, other than, I don't know what to say about that. I'm sorry.
Are all councils like this? That it's kind of, we just are for show?
For show?
That's what we feel like. We feel like we are meeting a requirement to have a council, but we aren't really used. And I think I know I speak for more than myself.
Yeah, I think that has been a prevailing sentiment, and certainly, Mark, we don't want to direct all of this at you. You're not responsible for all of that, but it does feel very frustrating that we've convened this council of experts that have very little to do with the actual process.
Yeah. I think when you look at the charter of what the council is organized for, it's difficult. I don't know that there's, other than advising the director, uh, or doing the website, there's a charge there, as the council has been established in statute, to advise on contracting, for example. And I know Shannon's got her hand up too. I guess I'm kind of reaching for support here in terms of OHA folks that can.
I will give you support.
Yeah.
I also want to support the council because I appreciate the input and everything that you guys have said in the past. So I will state, to my lack of involvement, I guess is probably the best way to describe this. When I was brought on, I was literally told by leadership, write this rule for the person that left with 2-day notice, which kind of left things a little bit straggled. And as you guys know, it took several years for us to get all of that through the system, even with the extension and approval through CMS and the legislature, to make sure that we get them. And Mark is right. We had to follow what was physically in the law, which means it didn't require specific metrics. It didn't require specific items to be included within the contract with the CCOs. And that's a very delicate process, to be honest with you. I am not familiar. Cheryl is an expert, and that team is the expert when it comes to CCOs. When you talk subject matter expert, there are so many different areas that we kind of overlap, and I can only speak to the language that's in the rule per the law that was actually passed. So the sad part is I can't help in regards to saying, yes, let's bring this forward and get the council involved with what's involved in the contract with the CCOs. That would probably be Cheryl and her team. And we kind of all cross each other's paths at some point. I do want you to know that you are heard. And it's important that you know that I am fully aware. And at some point, and I'm literally going to open up a can of worms for myself, but I'm just going to say it. At some point, I have to be tasked with opening palliative care for fee-for-service. And I cover my face because I'm a little nervous about it, and I'm trying to work with the state of Hawaii that has opened up a palliative care program for the islands. And so for those that don't know, Judy Moore Peterson is the director over there. So it's kind of nice that we have a familiar face that used to be our director. But this is something that, I'll be honest with you, I haven't even had the capacity to start looking into, because I would have to have 2 different payment methodologies. And we'd have to determine whether it's a bundled rate or if it's specific services. And so it's going to be very different for fee-for-service, but I will be reaching out most likely to this council at some point for literally input. So it is coming. I just unfortunately have had several other programs that I'm trying to get out of the dumpster fire they're currently in order to then move forward and be proactive versus reactive for some of these programs. And this is one of them, is being able to have the palliative care for fee-for-service. So I have the knowledge as far as what the law is, but in terms of what is required with Cheryl and her team as deliverables and CCO requirements, they can only go by what is physically within the law. That is all they're required to put within a contract. And I don't think there are those specifics, but obviously the council's input is super, super important. And hopefully it's something that can create a better system, a more productive system, a way to report out so that you have the data you're needing, as well as just communication in the field with said providers to be able to get them up and running for the service. I hope that helped. I know I'm babbling. I don't want you to think that you are not heard. You are very much heard. You are very much respected in my aspect, because I came in this blind and I still a lot of times feel like I'm blind with it, but I do want to move forward in a positive direction to make sure that you are heard and that we move to a point where we are able to all kind of work together. And again, I can't speak for the contract part, but I can only speak for myself and what I might be able to help you guys with.
Shannon, this is Barb, and I just wanted to voice for the record during this meeting that we have greatly appreciated all of the efforts that you have done. You took over a program that was trying to create rules, and it was in complete disarray, and you brought an openness and a willingness to buckle down and work and to listen to people and take input. And I just appreciate that, both in my role on the council and in my day job with the Oregon Hospice and Palliative Care Association. So thank you so much.
I also echo that, I have a real appreciation of the, what the council is, and also the hosted by the OHA, and, all the work you do. And, this is not, us, feeling our heart, hurting our feelings or not. But I just want you to recognize that, the expertise we have in this group, and clearly the, OHA and the other people who joined us these meetings have expertise in the rulemaking, and also other more understanding about the CCO process of the contracting and those things. But the majority of us here are the clinical expert, and those contracts needs to have the both side, like the CCO side and provider side. And if it is not well negotiated and speaking the same language, it's the resulting contract can be the more barriers or the challenges at the end and not benefiting to the patient. So I really appreciate what you said, and moving forward, please use our expertise to advantage and making this the work feasible and useful for our patients. So that is all the message we want to say here.
Seiko. Cheryl, you had your hand up, and then I know Linda and Jamie also.
Yeah, just real quick. Thank you again for the invitation to join the meeting today. I know Veronica and Leslie and I appreciate the opportunity, and we are meant to be resources to the council about the process. And I would strongly encourage you to give consideration to the idea of convening a subgroup that could do some work this summer outside of your regular meeting schedule to dive more deeply into the details of this process, because we've really given you only a high level detail. There's much more involved, and being able to work with a small cadre of folks from this group during the summer to dive into the details of what contract changes you might wish to propose, I think that could get some traction, especially with the entire process starting much earlier. It is a very detailed, involved process, and having more timely interaction and making good use of your expertise, I think would benefit everyone.
Thanks, Cheryl. Linda?
Ditto to what other people have said. Thank you for the work that you've done, Shannon. So we were not specifically naming you. I think part of our frustration is we do recognize that we're supposed to advise the director, and we sent a follow-up letter to a letter in April and haven't heard back. So I think you're getting frustration that is way beyond this process, and I apologize if it felt personal. I think Cheryl's idea of a subcommittee, or I know I'm not supposed to call it committee, Mark help me here, but a subgroup that we gets together and helps contracting do what palliative care providers and previous program managers would think would be appropriate is a good idea. Is that something that we need to have a vote on?
Well, I think you need to have some type of advisory group to staff. Wouldn't be a subcommittee necessarily, unless you want to hold a completely different public meeting and all the things that go with that. So I would need to I think I'm going to need to take this back with Jason, meet with Jamie and Barb, kind of see reach out to Cheryl and say, hey, what kind of things would you need to hear from us, and then get some structure and some guidance around how to spend that time wisely as volunteers. You're spending your extra time to outside a clinic to do stuff here, and how can we make the highest and best use of the time. You guys can make a proposal to do something, but anything that you do as far as a subcommittee will require public meeting process and separate meeting.
Are you able to hear me?
Yeah, go ahead, Jason.
Yeah. So again, if one or two people want to volunteer to work with me and Mark, we can meet and see about engaging in that process. And then we would bring any proposals back to a public meeting where they would be voted on. You could also create a subcommittee composed of fewer than a majority of those on the council. So it would have to be 4 people or less from the council. And that group could meet, but then those would have to be public meetings. So, and either of those would be possible. It'll be subject to our capacity to host them and schedule them and all that. But that would be the way to do something this summer, as Cheryl suggested, that might make its way into that process for 2027, 28.
So it sounds like the easier one, because everything takes too long, is to ask for volunteers. Do I have that correct?
Right. And again, it would need to be just a handful of people.
Well, I will volunteer. Anybody else up for this?
I will volunteer. This is Barb.
And this is Nancy. I have capacity this summer.
That's probably all about all we should take.
Probably.
And then again, just for transparency, we won't make those public meetings. We'll schedule with everybody, and then we'll report back to the next meeting of this council without communicating with the rest of you by email, because that would violate public meeting law. So we'll just be, you can always ask Mark individually, but you shouldn't be talking to each other about these efforts because of public meeting law. So Barb, Linda, Nancy.
Yeah, I've got those names written down. So
I had my hand up to say exactly what some of the other people have said, which is that I certainly don't want anybody to take personally our frustrations, and yeah, it's just it's been a long process of wanting our council to be used in a way that can be most impactful. And I think the subject matter expert discussion probably felt a little bit activating to a lot of us. So yeah, I certainly appreciate the work that you all do and know that you are also spread thin.
I don't take it personally, guys. I'm more of a let's figure it out, get it done. I know it's a process and it's taken a long time. I just have this envision of it being so much bigger than it already is. So let's get that done. And I say that as a whole for OHA, even though I have absolutely no authority whatsoever.
Yeah,
I'm the yes girl that gets into trouble. So, but if anybody needs my assistance or I need to be involved in any of those, I'd be more than happy to be involved. I'm going to need the knowledge moving forward of how to present this to our director and financial and all that other stuff for the fee-for-service side. So being involved and engaged in these conversations would be very helpful for me to know which direction to go. So
I'll say too, it's not uncommon in state government or any government to have different statutes that are created at different times for different purposes at different levels to address different goals, and it can be a challenge to bring them all together. And we're doing our best, as I think you are, to make this work meaningful. But it is just unfortunately part of working in, under the rules and structures and budget resources that we have.
So listening to the list of subject matter experts, it sounded really like they were more technical and financial than clinical. Is that fair, or was it just luck of the draw of what got
Oh,
mentioned?
that'd be accurate, Nancy.
Okay.
Yeah, and I think that's all the more reason that we would hope to have some input. Yeah.
And Shannon, I did a lot of fee for service and trying to set up different programs with fee for service. I'd be happy to spend an hour talking with you if that would be useful.
I'll
All
send
right.
you an email at some point and maybe we can schedule some time. That would be great.
And I know we're
Yeah,
at time here, so I think probably the letter that we were going to go over will have to be pushed to next meeting.
right. Yeah, I think at this point.
Yeah. Any final comments or questions before we adjourn? They move to adjourn.
Second.
We don't need a vote, but thank you all for attending today.
Thanks, everybody.
Thank you.